again if you would like.
Yeah, I thought we could go ahead and start the live stream.
Okay, just one moment, please. And if you don't mind, since I'm doing a roll call, I'll just go ahead and introduce the meeting, if that's okay. Dr. Bechtel?
This conference will now be recorded.
Okay, we're now live streaming. This is the February 10th, 2021 meeting of the State Medical Board's Medical Marijuana Expert Review Committee. And I will briefly take the attendance. Dr. Bechtel?
Present.
Dr. Soin?
Present.
I'm sorry. There we go. Mr. Giacalone?
Yes, here.
Dr. Schottenstein?
Here.
Dr. Reddy?
Here.
And that is the roll call. Thank you, Dr. Bechtel.
I thought we'd go ahead and get started. Between November 1st and December 31st of 2020, that's our petition period in which we receive petitions for possibly new qualifying conditions. And the board did receive 30 petitions to add qualifying conditions for medical marijuana. And again, we have very defined criteria as far as moving the process forward. The applications should have the name and contact information of the petitioner. A very specific disease or condition needs to be requested. We have to have information from experts who specialize in the study of the disease or the condition with relevant medical and scientific information. We have to look into consideration of whether conventional medical therapies are insufficient to treat or alleviate the disease or condition. There should be evidence supporting the use of medical marijuana to treat or alleviate the disease or the condition, and other types of medical and scientific documentation is helpful. And we also importantly need letters of support provided by physicians. As we look at those 30 petitions, we divide them into different categories. In category 1, the petitions to add a qualifying condition do not appear to meet the requirements of Ohio Administrative Code 4731-32-05. And in that category 1 of the 30 petitions, 17 appeared to fit within that category. Ms. Dorsey had one question. Proposal 0140 was on complex regional pain syndrome. And I wondered if that would have maybe qualified or had been covered by our previous chronic pain indications.
You know, if you don't mind, I would love to comment on that.
Yes.
Yeah, honestly, it would. Complex regional pain syndrome is a chronic pain state. I see those patients often in my practice. It is an orphan disease. It's incredibly debilitating. This particular application, there's 2 types. This is requesting for type 2, which specifically relates to damage to the nerve, of which the prevalence of that is very low, like 3 or something per 100,000. So it's not a very common condition, but it would be covered likely under the chronic pain condition. But I would like to point out the petition that was sent was literally probably less than 15 words. And the evidence was that this person had read about it online. And that's all I have to say.
So it appears that the application was far from being adequate at this point. So thank you. So we have 17 petitions that do not appear to meet the requirements for a petition. And our next step would be to move to reject these petitions. Do I have a motion for rejection as a committee? Dr. Schottenstein?
I second that.
Dr. Reddy?
Yeah.
So all in favor, say aye.
Aye.
Opposed? So we would then, I believe, Ms. Luca, present that then to the next board meeting with our recommendations as a committee to reject those 17 petitions.
Yep, that's right.
Moving on to category 2, we really didn't have any that fit in that category. So there's no action that needs to be taken there. As we move to category 3, those are ones in which the petitions do not appear to meet the requirements for a petition, but they were most likely covered by statute that already exists. And those would be 0138 fibromyalgia, 0148 multiple sclerosis, and 0151 post-traumatic stress disorder. So I think our proper approach as a committee here would be to reject those petitions, but then have the medical board staff reach out to the people submitting those petitions, letting them know that they're most likely already meeting a qualified condition. Any discussion on that? Dr. Schottenstein?
Hi, thank you. So, it seems like the complex regional pain syndrome would probably be a category 3, I'm thinking. And then the other thing, excuse me, and I don't know if I'm getting ahead of myself, but looking at the category 4 petitions, looking at arthritis, looking at migraine, also wondering if those 2 indications belong in category 3 as well.
Mr. Gaccalone, would you also like to comment?
I actually, Dr. Johnson said exactly what I was going to say.
Yeah, I also had the same feeling. I thought, especially osteoarthritis would fit in a already approved condition, qualifying condition with pain. I wanted to get some input from the members of the committee on the status of migraine headaches. So they feel it should also be moved into the category 3 category. Any input on that? Yeah, Dr. Schottenstein?
I guess my initial thought was looking at the wording of the statute where it states that the diagnosis or the indication, I should say, is being pain that is either chronic and severe or intractable. It seemed to me like it fit that criteria. That was just my impression.
I guess what we could do is take a vote of the committee on those that would want to move osteoarthritis and into category 3. We might vote on that first. All in favor?
Aye.
Aye.
Actually, we need can we have a motion for that first, please? In a second.
Oh, so moved. To move arthritis to category 3.
Second.
And we'll take a voice vote again. I'm sorry. All in favor, say aye.
Aye.
Opposed?
Right.
And then the other we were talking about was migraine headaches. Would somebody like to make a motion in regards to moving migraines from category 4 to category 3?
Can I make a comment first?
Yes.
And I may have misunderstood, but I presume Dr. Schottenstein was requesting or mentioning that migraines may be part of a chronic pain. And I suppose that's true if the migraines are chronic. Acute episodic migraines are not chronic. I don't know if those are covered. However, if they are intractable, I believe they would be covered. And I just wanted to make that known. And I believe, in my personal opinion, although I may not be an expert on how the definitions of intractable are, that migraines would be covered based on that logic. Acute, even, if they're intractable.
Very good.
And I think for purposes of our statutes or previous statutes, we've used intractable and chronic interchangeably.
So,
So should we qualify that in the migraine, as we say it there? I mean, should we say it's chronic? I mean, just so it's not, since people don't think it's just transient migraines.
Yeah, I think so. And there's precedent for that in the pain management literature. So, for example, when we use Botox, there's a definition for chronic migraines that the FDA recognizes, right? It's something like 10 or more headache days per month, that kind of stuff. So it's not like someone has a migraine once a year or something and it, self-resolves that they would be a candidate. I don't think that's the intention of what we're doing here.
Right.
I agree with all of that as well. Is there a way we can delineate that and make it chronic migraine?
Yeah, can we just lift off the statute, like chronic and intractable, and define it that way, maybe? So I'll allow, yeah.
So, Dr. Shenstein, I might have you maybe restate the motion or to move migraines to category 3.
Well, so I think I would restate it to say to move chronic migraines to category 3.
Okay, thank you very much.
Pleasure.
Second, Dr. Soin. All in favor, let's say aye.
Aye.
Opposed? Okay, thank you. Now, as we move to category 4, these are conditions that appear to meet the requirements to add it onto a qualifying condition. Of course, we have had expert testimony moving things forward, comments.
Mark, can I just interrupt you? The complex regional pain syndrome type 2, I don't know if we need a motion for that, or we just need to
I was just thinking that.
about, that it's under the chronic pain. I just want to make sure that didn't get forgotten.
Right. Why don't, I think, Stephanie, we could go ahead and make that motion now if you want to make that motion.
I think that's a good idea. That way we're doing everything the same.
Yeah, I would love to make that motion. Thank you. So moved.
I second that.
All in favor, say aye.
Aye.
And all opposed? So we'll move the regional pain type 2 into category 3. And now, as we look at category 4, these are conditions which, based on the petitions, appear to be meeting the requirements. There were 10 in that category. We've already moved 2 of those to category 3, migraines and osteoarthritis. And I will open up this discussion first to 0156 on autism spectrum disorder. I just want to comment. I do think the petitioner, Tiffany Carlisle, did present, quite a few new articles. A lot of it focused on the endocannabinoid system, which has been linked. I've done work with it in dermatology. There's a lot of neuroreceptors for the cannabinoids, and studies that were published from Stanford. There was a really good review by Dr. Christian Bogner. And my thought was that this has been looked at before. Obviously there was concerns expressed by Nationwide Children's Hospital, Autism Center, Cincinnati Children's Hospital, and also the Director of Mental Health from Ohio about the concerns of using medical marijuana in the treatment of autism and autism spectrum disorders. They have presented a lot of new clinical information, and I thought I would just have some discussion on whether we would move this forward for further expert review based on the fact that new articles have been submitted. And any comment? Dr. Schoenstein?
Hi. So I feel like we, as a committee, are substantially familiar with the autism petitions by now, and we have in the past had expert review on the autism. So I think that because there's still a public comment period that is ongoing, I think it would be premature to vote on it, as an indication at this point, but rather would wait until that public comment period has closed. I don't think that, speaking for myself, I feel a need for expert review on that indication.
Stephen, yes, Dr. Reddy.
I also feel that for the autism spectrum disorder, the long-term effects of cannabinoid system in young brain, I am quite concerned until I see some substantial studies that there is no side effect in the long term. I will be concerned about medical marijuana use in autism spectrum disorders. Particularly, this is a condition where we are going to use it in children. If it is autism in adults, it's a different story. But if it is young children, what would medical cannabis do to the brain of a young child?
Yes. Mr. Castellani?
Dr. Becker, I mean, you brought up Nationwide and Children's Hospital, which came in and basically presented to us on this topic. They were very specific on the dangers of this to young children. So there was nothing that I saw in the material that seemed to alleviate my concerns that were raised by that group to that. So I don't really see any reason for additional expert opinion there.
Stephanie, could we move this petition forward for further review, but then have the board be the expert witnesses in this, or expert reviewers in the situation?
Yes, Dr. Bechtel, that's what we did last year. So the committee is not recommending to reject at this time. It would be included when you set the public comment period today. It will be included in those types of conditions that we'll receive public comment on, and the board will serve as its own expert with respect to considering the petitions that were submitted.
Do I have a motion to proceed in that direction?
Move.
Dr. Shenson, second. Dr. Reddy?
Yep.
All in favor, say aye.
Aye.
Opposed? We also have a petition in regards to autism 0167 by Connors. Will we include that in the same discussion since it's the same topic? I thought we would also include that along with petition 0156 if the committee is in favor of that or accepts that.
Yep.
Then we move on to 0157 restless leg syndrome. Any comment on that indication? Yes, Dr. Shenson.
So, and that's a new indication for us. And I would be glad if we're able to find expert review on it, pro and con.
Yes. And I also wonder if it almost fits under the broad spectrum of spasticity and spasms. I think in reviewing the petition that was presented to us in restless leg syndrome, the petition came from Dr. Hurd, and it was based on his observation that one of his patients who was taking cannabis seemed to have less problems with restless leg syndrome. You go back and look at the articles that were then published that were cited. It was generally one author from France who, again, was mostly observational, that he saw that patients that were using recreational marijuana had less symptoms of restless leg syndrome, but no clinical trials or studies other than that. And then there was a short article involving 14 patients that had chronic renal failure on dialysis, and they noticed improvement in 7 of 14. So not a lot of robust literature was presented to us at all, mostly observational, very limited, no clinical trials. So I think it may be worthwhile to move it forward for maybe a neurologist or somebody to weigh in on that. I was concerned about the lack of robust presentation given. Any other thoughts on that? Do I have a motion then? Dr. Shenson, do you want to make a
Yes,
motion?
please. Sure.
I'll second that.
Second, Dr. Reddy, to move forward, at least to have further neurologic expert opinion, maybe both ways on its benefit, and that'll allow it to be. We'll have comment on it, public comment also. Moving on to Huntington's disease.
I'm sorry, Dr. Beto, could we have a quick vote on that motion?
Oh, I'm sorry. Yes, Ben. All in favor of the motion, say aye.
Aye.
Opposed? Thank you. Yeah, thank you, Benton. Moving on into Huntington's disease, presented by Dr. Douglas Wu, and our health neurologist. As you know, Huntington's disease is a very debilitating condition, no FDA-approved treatments. he presented some evidence of the fact that the basal ganglia has a lot of cannabinoid receptors that might be a therapeutic target. Does anybody want to further comment on that petition? Dr. Reddy?
Yeah, when we look at out of the 22 medical conditions we approve for the treatment with medical cannabis, we have 9 in nervous system. Includes Alzheimer's, multiple sclerosis, Parkinson's disease, spinal cord disease or injury, TBI, which is traumatic brain injury, ALS, chronic traumatic encephalopathy, epilepsy of seizure disorder, and Tourette syndrome. So if you look at these conditions, some of them are neurodegenerative. We don't have a particular answer or a particular treatment. And into that category, Huntington's disease fits in quite nicely. It is a neurodegenerative disease and it is genetic. And we do not have any treatment whatsoever which would help this condition. I do think that this is a very, very genuine condition which we need to approve and have more experts. And I do know if you go through the records, there is an expert right around here in Central Ohio, a physician from Mansfield, and he is trained, I think, in Johns Hopkins, and he has expertise of 200 patients. I would love to hear his expertise on this before we say yes.
The neural tissue has a lot of cannabinoid receptors, so it is a good target for medical marijuana. If you look at Huntington's disease in general, the basal ganglia has many cannabinoid receptors, so it's a potential therapeutic target. And the letter I think was by Dr. Rajan, who's a neurologist in Mansfield, who also is an adjunct professor at Johns Hopkins. Would somebody like to make a motion to move this forward for expert review?
I will make the motion.
Dr. Reddy, second.
I'll second.
Dr. Shantz. All in favor, say aye.
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 Opposed? The motion passes. The next one is 0160 on panic disorders with agoraphobia. Dr. Shantz, could you comment on that for us?
So I approach it much the same way that I approach the autism indication. We are familiar with it as a committee. It's coming back to us again as a repeat, and we've had expert review, I should say, before the committee in the past with regard to this indication. And so, again, I think I would approach it the same way that I would approach the autism, which is to say, be respectful of the public comment period, but I don't feel a need to have expert review regarding this matter.
Any other discussion? I'm in agreement with your
I would agree with Dr. Shantz. I agree with him.
Dr. Shantz, would you like to make a motion?
I'll move to that effect, please.
Second?
Second.
All in favor, say aye.
Aye.
Opposed? And the motion passes. I thought before going to terminal illness, I might go to spasticity and spasms. Again, that's kind of in the neurologic spectrum. Dealing with a lot of the disorders like we talked about with restless leg syndrome and Huntington's disease. Dr. Reddy, would you like to comment on that and whether or not you feel it would be worthwhile to go ahead and move that forward for expert review?
So here is what I think. When I'm looking at the conditions which we have agreed, there are certain overlaps which I would like to bring to the board's attention. For example, when we say spasticity and spasms, it generally occurs in multiple sclerosis, spinal cord disease or injury, and in traumatic brain injury. So I was having difficulty where to place this spasticity and spasms. Do we not already cover it under multiple sclerosis, spinal cord injury? So I had a specific question to ask this committee. When we say MS, for example, multiple sclerosis is a broad spectrum. Do we say that if a diagnosis of MS is established, we could use marijuana for that? Or is there a very specific indication in MS?
To me, it seemed like the definition of multiple sclerosis was pretty specific. So it's spinal cord injury. So this would, I think, broaden the definition of spasticity. Making it possible for providers to treat spasticity outside of the setting of multiple sclerosis.
Yeah, unfortunately, the legislature put the criteria down here, so we didn't. So we don't, to define it, it's a little bit beyond our scope. So, I mean, if it's multiple sclerosis, it has to be, in my opinion, a diagnosis of multiple sclerosis triggers the availability of marijuana. And it probably has to be pretty, in that box. If it's out of that box, spasticity to something unrelated doesn't get the nod.
Yeah.
But to your point, it's compelling, right?
Yeah.
That it is so reminiscent of something that's already been approved.
Yes.
So on a similar lines, I was going through the other indications. For example, you have ulcerative colitis and we have Crohn's disease. And we yet have another condition called IBD. So when we say inflammatory bowel disease, it encompasses both ulcerative colitis and Crohn's disease and maybe something else. So I'm just thinking, as we keep on adding more conditions, maybe we should categorize them. Let's say Crohn's disease and ulcerative colitis fall in inflammatory bowel disease.
I think those are indications, I think, that were defined by statute, I think, weren't they, by the legislature?
Yeah, the legislature enacted those indications. So to your point, it's, always been curious to me as well, that those things are, specifically laid out like that. And really there's some redundancy there. And so those were the original, in the original language that was, passed through. And now, I don't know that we have the ability to sort of unilaterally categorize, even though what I hear you saying makes sense. I don't know that we have the ability to do that. The way that the process is set up is we get the petition and then we up or down vote on the petition.
Yes.
Same thing holds good. If we think about hematology and oncology, there is AIDS and we have an HIV positive status.
Yes.
So there are two conditions and two different names for the same disease.
Yeah.
So how do we categorize them? And if it is legislative, then we can't do anything. But as a board, if we have to do something, I think we need to have a protocols going forward, because as I see it, we will be adding more and more conditions.
I think the best we could probably do is have some conversation with the legislature about how things are categorized, right? So I wasn't here at the time, but when the statutory scheme was created, the legislature decided upon these 20 or so conditions, and then the medical board came into, as Dr. Schottenstein and Bob described, basically say, well, we can add to this list. We can't take anything off ever. We can continue to add. We can't really modify it because it's in code. So I think that if we want to think about the the statutory scheme itself and provide feedback, we'd probably be best to do that through the legislative process and kind of provide the legislature with an update on our programming.
So similarly, we have traumatic brain injury and we have chronic traumatic encephalopathy. So isn't both the same, traumatic brain injury and traumatic encephalopathy? So if we talk about encephalopathy, it should not be traumatic. It could be any other condition.
Yeah. Again, I think what makes things difficult is that a lot of qualifying conditions that came out for medical marijuana were defined by the legislature. And as you know from reviewing things, a lot of it was based on very little evidence-based medicine, medical review, or other, significant medical contributions that we would really highly regard in medicine as being significant. So maybe it's something with Ms. Luke and other working with the legislature, we could, moving forward, do things to, develop categories that made more sense, and rather than like splitting into little conditions here and there, having more broad categories that they really fit together into one type of medical spectrum.
To Mark's point, you're looking at it as a physician. This was written by lawyers. I can tell you lawyers don't understand the differentiation here. So unfortunately, because they drive the legislation, this is it. This is your box. That's why we have the provision, for the medical board to expand that if necessary, right? So that's where, unfortunately, it's more work for us, but that's the gauntlet we have to run to get the things done. So no offense, but we're not going to change these. The best we can do is add to them.
Right. Does anybody want to make a motion to move spasticity and spasms forward for expert review?
I'll move.
I second that.
Is that Dr. Reddy? All in favor, say aye.
Aye.
Opposed?
Aye.
Motion passes. And now the last two really deal with terminal illness, 0161 and 0163. Those are the last two to focus on. Patients that are terminally ill, they define this as having 6 months to live or less, have a lot of conditions that may be already covered by previous indications, including pain, nausea, and things like that. Does anybody want to comment on these indications, qualifying conditions? Yeah, Dr. Hornstein?
I think that we'd be right to proceed with expert review for this indication. It's new for us as a committee, and I would be glad to have that additional input.
I agree. Yeah. Any further comment? Does anyone wish to make a motion, Dr. Schottenstein, to move it forward?
Thank you. I did have one more quick comment, though, actually, which is more sort of broadly. The conditions that we're contemplating moving forward are, with the exception of terminal illness, they're substantially neurologically based. So if there's a way to simplify things and have an expert who can comment on more than one indication, that might make things easier as well for us.
Yes.
I think that's great. Yeah, I think that would be our plan, would be to try to find one for the three. Great.
And then as to the terminal illness, potentially somebody who works in, palliative care or something along those lines. And Dr. Ron Factora, who specialized in geriatrics and was on the board at one point, might be a good resource to help us find somebody in that regard. But so thank you for that. And so, yes, I'd like to make that motion.
Do we have a second? Oh, Dr. Reddy? Okay. All in favor, say aye.
Aye.
Opposed? Aye. The motion goes forward. And then Brandy, do we need to make an official recommendation then to move these recommendations forward to public comment? Or is that done automatically?
I believe it's done automatically. Or do they need to make a motion? Okay.
Yeah, we need to have you set the public comment period.
Yes, I'd like to set a public comment period from beginning on February 11th and then closing on February 26th with directions on where they can also send written comments to.
I'll definitely second that.
Okay, thank you. All in favor?
Actually,
Yeah.
since you're presiding over the meeting, Dr. Bechtel, if we could have Dr. Johnson move the motion,
Yeah.
somebody else second it, that would be.
Sure. I'll move. Thank you.
And second,
I second that.
it's been moved by Dr. Shanstein, second by Dr. Reddy, and all in favor say aye.
Aye.
Opposed? Thank you. The motion passes. So this then concludes our medical marijuana committee meeting. Appreciate everybody's input.
Dr. Bechtel.
Ms. Dorsey, do you have a comment?
Yeah, Dr. Bechtel, I know we're running a little behind on time, and there was one other agenda item that we wanted to touch upon quickly, and that was the physician surveys, the annual reports,
Yes.
and what the committee's thoughts were on the responses for those. I know that the response period last year fell right during when everybody was being told to go home when the COVID outbreak started. And so there was some leniency regarding the physicians who didn't respond that were in the program. Just wanted to get your ideas on moving forward as we look forward to setting that response time for those CTR physicians, how you wanted to look at that moving forward, the ones who didn't respond.
Yeah, are you referring to physicians have to kind of document that their patients are responding to therapy? And
Yes.
I think it's important based on the legislation, rules and regulations that we move forward with that.
I agree. Did you guys want to discuss either at this committee meeting or the next one, possible how to handle the physicians who don't respond? Do we send a caution letter? Jerica's been very proactive at getting a lot of information out in the newsletters and online. So any thoughts on that?
I would have said a caution letter made sense.
Yeah, I would agree. I think a caution letter would be important to do. And then, if we have any.
I have a general question. Out of all the CTR physicians, what percentage are actively recommending and what percentage are not at all involved?
I believe.
Stephanie, you're muted.
Sorry. Jerica, do you remember the number off the top of your head? I want to say it was only a third were actively recommending.
I think it was the opposite. To my knowledge, we've never gotten an official, full report. The Board of Pharmacy has probably the ability to see that because the registry is controlled by them and managed by them. But in the survey we did last year, we got a little over 2/3 response from the amount of CTR physicians, and 34%, I can go back and check that, said that they had never made a recommendation. That was either responding. Let me double check. Yes. Make it bigger. Yeah, so 34% last year had not ever made a recommendation from those who responded.
Thank you. So I think caution letters would be appropriate. Yeah.
Thank you.
Any other business before the committee? Any motion to adjourn?
Move.
So moved. Second? Dr. Reddy? All in favor, say aye.
Hi.
Thank you.
Thank you.
Nice to see everybody.
Bye, everyone. See you in a few.
This conference is no longer being recorded.